Hi guys, Dr. Gillard here. Let's do another lecture on lumbar spine anatomy. So it is week 4 in the spring of 2020 and it's Tuesday. So we left off on ligaments of the lumbar spine and we talked about anterior longitudinal ligament. Turn my marker on there. Which the key, here's something to remember. The anterior longitudinal ligament, I'll tell you right now about it. It gets more narrow the higher you go up toward the cervical spine. In the cervical spine, it's just a little cord. So that's important to remember. Really easy board question. The posterior longitudinal ligament is the opposite. It's much wider up in the cervical, and it narrows as you get down to the lumbar spine. Although in the lumbar spine, it also has a second component, some lateral fibers, which kind of make up the difference to that. But that's a nice little juicy board tidbit there for you, and my test tidbit. All right, so we talked about these other ligaments. There's ligamentum flavum we'll look at. There is the posterior longitudinal ligament back there, the main fibers of it. We will look at the supraspinous. Number 8 is the supraspinous ligament. And number 9 is the intertransverse ligament. And we have an interspinous ligament. We'll look at those today. And there's ligamentum flavum again. There's the nucleus pulposus annulus fibrosus of the disc. So we are all good there. Make sure you know those right. I think that's in today's lab. And then I threw this one in there just to show you the yellow ligament. We'll talk about that more today. And then we have a facet joint capsule that's important, or zygapophyseal joint capsule, if you will. All right, the ligaments of the posterior elements. What does that mean? Ligaments of the posterior elements. That's the posterior arch, or the vertebral arch. Remember, the vertebrae has two parts, right? It has an overhead view. It has a vertebral body, which is kind of block-like. And then it has an arch of bone that comes over the back side. Did I mess that up? Of course I messed that up. But there's an arch of bone made of the pedicles, the articular pillars, the lamina, spinous process. Might as well finish it off. TPs here. But two parts, vertebral body in the front and then this ring of bone. And so this is also called the posterior elements. Posterior elements are usually attached to this ring of bone here. So therefore the posterior elements are ligamentum flavum, interspinous ligament, supraspinous ligament, and the facet joint capsules, or the zygapophyseal joint capsules. Right? I think this is new for us, but we need to start learning this stuff. I think this is in today's lab as well. This is a sagittal section of a motion segment, mid-sagittal in fact, and it's a cut through the disc. Here's the anterior portion of the disc. Here's the posterior portion of the disc. We removed the vertebral body above, but we kept the inferior member of the motion segment. And I want to talk about a couple things here. So the disc, of course, has two parts, a nucleus pulposus, which is made up of proteoglycan cells for the most part, or proteoglycan molecules, which are secreted by nucleus pulposus cells. They hold water, so there's about 80% water here. The annulus fibrosus is made up of about 15 to 20, depending on what author you read, really strong bands or sheets of lamellae, they're called, type 1 collagen. We'll look at that soon if we haven't already. But yeah, so it corrals the squishy nucleus so it can't escape. But what we haven't talked about, let's talk about this. So the disc is wired for pain. In the back part of the disc here, we have these little lollipops, and those are nociceptors. What are nociceptors? Those are little pain triggers, and they if you set these off, it sends the sensation of back pain up to your brain, maybe even referred leg pain as well. But also mixed in, you have some blood supply in there as well. And so this all happens in the very outer periphery of the disc. The inner periphery has no blood, has no nerve fiber either normally. Okay, and we remember we talked about an annular tear can occur from lifting something really heavy and not having great genetics. But if you rip the back of your disc here, because this stuff is under pressure, I guess it's blue, this stuff can squirt out the annular tear, and when it gets out to here, in some but not all people, it can cause horrible, horrible pain. If an inflammation occurs, you're going to have pain. Why some people don't get an inflammation and others do is the great mystery. You want to win a Nobel Prize, figure that one out. Because some people end up, they have to take the disc out via fusion. And other people, they don't take the disc completely out. But beyond the scope, go to my website if you want to learn more about fusion. Right? But that's an annular tear. The point I was going to make, though, so the annular tear, in order to repair the annular tear, these nerves actually have to grow. I guess they're yellow. They have to grow all the way down in the center. And so once somebody receives an annular tear, we know this from autopsy studies. Once somebody receives an annular tear, your disc is basically wired for pain. Kind of getting off subject, but so back to the point of the subject. Now we have two regions here. We have the vertebral end plate, but we have a superior vertebral end plate, and then we have a bony versus a cartilaginous. Is what I'm trying to say. So we have a cartilaginous region right here, which is some consider part of the disc. Then under supporting that, and on the sides of that, we have a bony vertebral end plate. This is the superior bony vertebral end plate. There would be an inferior bony vertebral plate under here. The cartilaginous vertebral end plate is actually part of the disc. You can consider that because, let's see if we continue these lamellae, what they really do, they actually go through the cartilaginous end plate. They come out the other side, right? Not all of them, not the very outer fibers. Right, so the nucleus is really surrounded by this stuff. The outer ones dig into the bone here, and they're called Sharpie's fibers. They don't loop like that. But yeah, so I wanted you to know the difference between cartilaginous vertebral end plate. That's a little tiny pad. Now that, and all the specimens that you'll see in lab, there is no cartilaginous end plate. There's no disc, right? That's all been kind of melted away in the bone preparation process. So really all you're seeing is a superior bony end plate and a vertebral bony end plate. But in the living, there is a little pad of cartilage, almost like articular cartilage, but it's not. It's much looser than that. Pretty good with that. I think I got everything on that. So we talked about the anterior longitudinal ligament, but let's really get into that ligament a bit here, shall we? Oh, here's a picture of it again. Down in the lumbar, it's really wide down there. Remember, it gets skinnier as it goes to the top. There's the lateral portion of the posterior longitudinal ligament, interspinous, supraspinous. But yeah, let's dig into this thing. So it's a wide band of ligament. It covers the anterior aspect of the vertebral bodies, the end plates, and some places it digs into the disc and attaches, but not most places. It's made up of type 1 collagen, just like the lamellae of the disc, so it's super strong. It extends inferiorly to the sacrum and superiorly all the way to the occiput, right? So it runs all the way up. Posterior longitudinal ligament doesn't extend past C2 or past C1, but the anterior longitudinal ligament goes all the way up, so that's a difference between them. That's a good question. Right? So it covers every single vertebrae except the sacrum and the coccyx, like S2, 3, 4, 5. It doesn't cover those. But there's another ligament that covers those we'll look at. It's said to grow steadily wider as it descends from that should be cervical region. I just whipped these slides together today, so let's fix this slide 232. Yeah. And intersegmental fibers attached to the vertebral end plates. So it's attached everywhere to the vertebral end plates. Does it attach to the discs? Mainly no. Unlike the posterior longitudinal ligament, the ALL doesn't attach usually to the lumbar or cervical discs. However, in the thoracic spine, it actually anchors into the anterior part of the disc in about 50% of the cases. Bogduk stresses that it should not be considered part of the annulus fibrosus. And in the cervical spine, as we said, it gets narrow. In fact, it gets almost cord-like, and it runs exactly in the midline. And it connects especially between atlas and occiput. And this cord attaches to the body of axis, and we'll talk about that when we get to the cervical bones. But it attaches to the tubercle of atlas. It doesn't attach to the anterior arch of atlas. So usually atlas is weird because it has this arch of bone, and it has these lateral masses. It doesn't have a body, but it has these lateral masses. This is a terrible drawing of it. It has these lateral masses, and then it has a posterior arch on the back. This is an overhead view. And off the anterior arch, we have the anterior tubercle. So that is where, this is overhead view, so you would see the anterior longitudinal ligament connected right to the tip of that. There's another ligament that is connected here to the anterior arch. Although the two blend together, their origins are not the same. So that's the part I'm trying to make there. The anterior atlanto-occipital membrane is actually right here. And the ALL is actually right here. Good with that? All right, so laterally it bends to the anterior atlanto-occipital membrane. There's an important posterior atlanto-occipital membrane. Talk about when the time comes, but sometimes the picture is best. So here's the upper cervical. This is the occiput here. This is the weird atlas. Doesn't have a vertebral body. This is the weird axis. But here is the skinny anterior longitudinal ligament, and it goes right up and connects to the occiput. But the point is, we have a new kind of band of tissue right here that is called the anterior atlanto-occipital membrane that kind of blends in with this and gives it some strength. If you go out even more laterally, you have the capsule covering the facet joint here, although we don't call it a facet joint. We call it the atlanto-occipital joint. That's the joint capsule of the atlanto-occipital joint. Blends in with the anterior atlanto-occipital membrane, which blends in with the anterior longitudinal ligament. So that's kind of the story up there. Here I kind of highlighted it in green so you can see which is which. So that's the skinny little ALL. Okay, remember how big it was here? Look how big it is here. And it gets super skinny as you go to the top. If you really want to get into it, it is subdivided. The ALL is subdivided into many different bands. One band of ligaments just attaches between adjacent motion segment members. Another band attaches between two segments. Oops, I lost where that was a terrible color. Well, you can see the arrows here. Then another one 3 and another one 4. So these are all mixed together. So you have varying types of bands in here. That makes this a very strong ligament is the point here. What is the function of the ALL? Well, you can't bend backwards, right? Well, I mean, you can bend backwards, but picture this spine. Get rid of that color. Bending back like this. It's going to stretch this ligament right here. So it helps limit extension of the spine. Helps limit extension of the spine. Okay, so it's engaged during extension. It resists or limits lumbar extension, and frequently damaged in car accidents. If you get hit from behind, your head whips back and forth, right? So here's, heaven forbid, I'm going to try to draw this. Here's the guy's head. So if he gets hit from behind, here's the car coming from behind. Here's his nose. If you get hit from behind, your head whips backwards like this, hits the headrest, and then rebounds forward like that. So you get this back and forth. That's called whiplash. This is a side view here. All right, so that's called whiplash. And the anterior longitudinal ligament, as your head goes back, especially if you don't have a headrest, it stretches. It's so strong that it actually can rip the bone that it's attached to off. And when that happens anywhere in the body, when a ligament rips a chunk of bone off, that's called an avulsion fracture. So here's someone who was in a high-speed rear-end type motor vehicle accident. This is a mid-sagittal cut through the cervical spine. And you can see the AL has ripped a chunk of bone right off the front of that vertebrae. See, the other ones don't have that. There's the body of C2, C3, C4 is a problem, C5 is fine. But yeah, that's an avulsion fracture. You have to be careful as you go through the radiology program. There's things called persistent apotheosis. That's a growth plate that failed to turn to bone, and it can leave these little chunks. But in this case, it was an avulsion fracture. What else can happen to the anterior longitudinal ligament? There's diseases that can affect the calcifying diseases. One in particular is called diffuse idiopathic skeletal hyperostosis. And you can see this. This is a parasagittal view of the lumbar spine. You can see the intervertebral foramen. But you can also see, still a view from the side, look at how the ALL is all calcified together. So this is classic dish. And you'll talk about that as you get in the upper quarters. That's all I'll say about it. But it can cause dysphagia. All right, we had some technical difficulty there. I'm not sure what exactly happened. But here we're back. So we're just finishing up talking about dish, how it can cause dysphagia and odynophagia. There's other conditions, though, that can... Well, I mean, dish is pretty... This is dish. But sometimes you don't get so much. Maybe the calcification is more linear. In fact, it's called bamboo spine. That's something you'll see in one of our terms. We already talked about ankylosing spondylitis, when the spondylonegative seronegative spinal arthropathies, right, with HLA-B27 positive. That gives you a bamboo spine appearance. So that can also affect the anterior and the posterior longitudinal ligament. All right. So here is a patient with dish. You see it flowing down here in the cervical spine. Right? In fact, they have the bird beak sign. So that's kind of, here's where he's swallowing. It's up kind of right between there's the oral pharynx. The oral pharynx would be about here. His mouth is closed there. Here's the nasal pharynx. Soft palate would be right here. So it's bugging him every time he swallows. Time that soft palate goes up, it kind of rubs over this and causes trouble when he swallows. Odynophagia is actually pain swallowing. Dysphagia means it bugs you swallowing, but it's not flat out pain. All right, let's go to the posterior longitudinal ligament. Just like the anterior longitudinal ligament, it's seen throughout most of the spine, but its fibers generally narrow as you go down. Remember, the width of the fibers get narrow in the anterior longitudinal ligament as you go up from the lumbar to the cervical, but just the opposite of the posterior longitudinal ligament. They narrow as you go from cervical to lumbar, the width of these fibers. Okay, the extra, as I said before, it has some extra lateral fibers that kind of go out to make up for that. They're not as strong as the center fibers. And, yeah. So the lateral fibers are said to give the PLL kind of a serrated type look. If you look closely at it, it kind of looks like it's chewed up through here. So these are the lateral fibers. The main fibers are stronger, though. Right in the middle here. All right, just like the ALL, there's different bands as well. There's some of the fibers, you can follow them running just between two motion segments. Some of them go between 3 or 4. Some of them go between 4 and 5 segments. So again, this type of design makes the ligament really, really strong. They all blend in. This is an important point. Unlike the anterior longitudinal ligament, where usually none of them are attached to the disc, maybe about half of them are in the thoracic spine, in the posterior longitudinal ligaments, they all blend in with the posterior portion of the disc. So they are attached to that disc. Therefore, central disc herniations, a herniated disc right in this region, it happens. I see them all the time. but it's not the normal because it's really strong here. Disc herniations usually happen right up in these little corners here, as we'll see. But it can happen anywhere. This is called the paracentral zone, for those of you who want to know everything. Foraminal zone would be right here. Sometimes that's called the subarticular zone. Far lateral zone would be out here. Those are the herniation zones, and this would be the central zone here in the middle. All right, so I said the PLL doesn't go all the way to the foramen magnum. It actually morphs into something else. I mean, it really does, but we call it, because the fibers look so different under a microscope, it's given a new name. And so, so at the level of C2, here's C3. As it gets to C2, the fibers change enough where it's called the tectoral membrane. Tectoral membrane is what actually connects to the anterior part of the foramen magnum. The PLL stops at the level of C2. Good board question, easy board question. So the ALL goes all the way to the occiput. Remember, this one does not. It stops at C2. Okay. Down at, oh my God, are you freaking kidding me? I just can't catch a break today. We lost one recording because these leaf blower guys are just gone crazy today. They're trying to clean all the streets, and they're just, I don't know what the hell they're doing, but I'm about ready to go strangle them. I'm sorry, we're just going to have to push through it. So, yeah, so it morphs into this new tectoral membrane there. And, yep, at S1, so if we go down low, remember we talked about this already, it stops, the PLL stops at S1, but it continues down as the deep dorsal sacrococcygeal ligament, right? And we talked about that one already. It's 3 to 4 times thicker in the cervical spine than the thoracic or lumbar spine. There is a spot, a weak spot, which we talked about, on the superior posterior lateral kind of corner of the disc. I'll show you a picture of it. But there's actually no posterior longitudinal ligament there. And herniations can actually occur right in that place. Okay, and this is why paracentral herniations are so important. So let's look at this work by Lee et al. In 2018. So here is the main fibers of the posterior longitudinal ligaments. And these are these lateral fibers that go out. And we have a little window right here where there's no tissue. And once you get here in the subarticular zone, they tend not to occur anyway, and the disc is a little thicker. But right in this little window here, there's a real cadaver specimen. That's where herniations tend to occur. But from my experience, the annular tears can occur anywhere in here. They're not going to come through here because it's so thick. They're going to come right in this paracentral zone here. So here's a patient of mine, severe right radicular pain. So remember, we're really looking from the ground up. So the sides are reversed on CT and MRI. So that's the left. This is the right. That's an overhead view here. This is a cut going right through this disc. You can clearly see a disc herniation here. You can also see a Tarloff cyst right here. I won't get into that. I have videos on that though. But anyway, so yeah, so he had really bad pain, and examination revealed he had an absent right Achilles reflex. He also had numbness in the lateral foot. It's tested with a Taylor pinwheel, not a Paler pinwheel. I got a fix 49 as well. Fix 349. Okay, and then he had weakness when we had him do single leg calf raises. He had no power in his right gastroc. That's a perfect match for an injury to this nerve root. That's the S1 nerve root. So he's diagnosed with a radiculopathy. MRI was ordered, and sure enough, he had a huge right paracentral disc herniation that stemmed right in that weak spot. It wasn't in the center. It was right off to the side. This is a run-of-the-mill, pretty big one, but they get way bigger than that. And yeah, he actually came out of it. You don't always need surgery with these things. Sometimes Mother Nature will reabsorb these things all by yourself, whether you have any treatment or not. But anyway, here's the left, this little dot here. There's the left S1 traversing root. The right one is completely smashed back here, and that's why he had those types of problems. What does the PLL do? It resists separation, just the opposite of the ALL. It resists separation of the posterior ends. So axial distraction is resisted on the posterior, but better to say it resists lumbar flexion, right? If you bend forward, it's going to pull tight, and it resists flexion. And its action, because of the multiple fibers, it's exerted over several vertebral bodies. And yeah. Inverted, so the PL or innervated. The PL is well innervated. We didn't talk about the AL. That's innervated by sympathetic afferent fiber, which is not thought to really carry the signal of pain. Unlike that, the posterior longitudinal ligament is really innervated with nociceptive fiber from the sinovertebral nerve. And you're going to learn that sinovertebral nerve today. Cramer says it's one of the most pain-sensitive structures in the spine because of the density of sinovertebral nerves around it and in it. So if it becomes inflamed or compressed or ripped from a disc tear going through it, it can be a really bad source of tear, or a leaking annular tear, right? You don't always have to have a herniated disc. So this is another picture from lab, but here's the corner. There's the thecal sac. There's a lamina, superior articular process, inferior articular process, transverse process. Let's go through these because you're going to have to know them anyway. This is the exiting nerve root. That's the one that comes out of the hole. This would be, there's the dorsal root ganglia. So this is the dorsal root ganglia of the exiting sensory nerve root. This is the motor exiting motor nerve root. They come together to form the spinal nerve. Spinal nerve splits into a posterior ramus and an anterior ramus. This goes on to make up the, depending where we are, but the sciatic nerve or the femoral nerve. These wrap around. These are the posterior rami. They wrap around to the back, and it gives off a medial branch. So there's the medial branch of the posterior ramus, and that's what gives life to the facet joints. People with damaged facet joints, you're going to treat a lot of them. That's our bread and butter right there, but it's supplied by the medial branch. Okay, and then this also goes up to the multifidi muscle. We have an intermediate and a lateral branch as well. I'm not so worried about them. But the point is, here's all these little lollipops. Those are the sinovertebral nerve. Those are nociceptors. If you look close, you can see the posterior longitudinal ligament in pink here is also filled with those same nociceptors from this orange guy here. This is the main root, main trunk of the sinovertebral nerve. It actually dumps in to the anterior ramus, and if we could look inside, we'd see the nerve fibers intermingling with the rest of the sensory nerves, and they go into the dorsal root ganglia, and they have a cell body there and the whole 9 yards. And these same sinovertebral nerves, they also supply the anterior portion of the thecal sac, which is dura mater, right? So they're plugged into the dura mater. So this can be a source of pain as well. All right? So I think I covered all that. You're going to need this for lab, but these are the lamellae. We talked about those. Annulus fibrosus, sinovertebral nerves or nociceptors of number 4. Where I can't find number 4. There's 4. Still sinovertebral nerves of the thecal sac. Number 5 is the dorsal root ganglia. You could say of the exiting nerve root specifically, which I want you to be specific. It's the L4 exiting nerve root. Number 6 is the motor exiting nerve root. Which one? L4. Number 7, that's the spinal nerve. Which one? L4 spinal nerve. Number 8 is the anterior ramus. Number 9 is the posterior ramus of who? These are all L4 property. 10 is the medial branch. 11 is the lamina of who? Because this is the same slice you're going to see on a MRI or CT. These are this is the lamina of L4. All of this property from here to here is L4. What's 14? Inferior articular process. Pars interarticularis would be getting close to that. But this is inferior articular process. Who's number 13? Of L4, who's number 13? That's coming out from deep inside the plane of the page. That's the L5 superior articular process coming from the vertebrae below that we can't see. Okay, there's the pedicle of L4. Who's 13 again? Superior articular process of, good, L5. Now we're getting it. Okay, let's jump into here. What's number 16? It's called the epidural space. You've heard of an epidural injection? That's the epidural space. I should have put one in here. What's 16 and a half right in here? Well, if this is epidural, this is interdural or interthecal space. Okay, 17. It's the thecal sac or dural sac. How about 20? It's pointing to that orange thing. That's a sign of vertebral nerve, aka recurrent meningeal nerve. Got to know that stuff. Right? How about 3? And now we're talking some sympathetics. This is the gray ramus communicantes or gray ramus communicans. Right? You know this from anatomy, gross 1. Lumbar sympathetic ganglia. Here's some anterior sensory fibers, afferent fibers, sympathetic, which connect to the periphery of the anterior part of the disc and the lateral part. That's why we don't think tears into this region are painful. Right? In the worksheet, I think I got everything, but I think you could figure everything else out. I think I got everything. And there's all your answers, so make sure you know that. Guarantee you this will be on the lab test and on the final or on the midterm for lecture as well. Got to know that stuff. Cervical spine, central stenosis, cervical spinal stenosis, also called central spinal stenosis. I'm actually going to fix that. 355, it's central stenosis. So you can get a thickening of the posterior longitudinal ligament. It doesn't really matter in the lumbar spine or really the thoracic, but cervical spine's a tight squeeze and it can squish the delicate spinal cord in that region. And then if you have ligamentum flavum thickening in behind, the two of them can pinch the spinal cord and cause all sorts of trouble. And you're going to see more of these patients than I did because you're treating all the old baby boomers. And they are going to have myelopathy. Some of them are going to have central spinal stenosis here. And yeah, that's the most common cause of myelopathy. And you got to worry that maybe they have some other demyelinating disease, because there's other demyelinating diseases, right? Like multiple sclerosis is the first one that comes on the list. So it can be difficult. In fact, they did a study on how long it took to get the diagnosis of myelopathy. It was 6 years, and many of these patients were at chiropractors and physical therapists. They all missed it. So number one symptom that you have to watch out for, about 90% of these patients have reported clumsiness, whether it be with their hands, like they can't keyboard or mouse anymore, or type or write, or with their gait. They have gait disturbances where they're getting a little wobbly, especially in the dark. Proprioception is knocked out. You can do a Romberg sign to test for that. That's you just stand with your eyes closed, have the patient stand looking straight ahead. You stand behind them and watch for how much sway they have from side to side. Then have them close their eyes and get ready to catch them because they might fall down. If they get really wobbly, that's a positive Romberg's, and that means that their proprioceptive tracts are not working. And that could mean that the proprioceptive tracts, which are in the dorsal and dorsolateral part of the spinal cord, are compressed from this cord being squeezed. They typically have cervical spine pain as well. And about 80% of them, when you do your careful neurological evaluation, they'll have hyperreflexia. They'll have a Hoffman sign. They'll have Babinski sign. You'll learn about all these as you go through the program. But see, we can put that to use. So there are conditions that can ossify the posterior longitudinal ligament, especially in Asian peoples are notorious. In fact, that's the name of the disease. It almost exclusively occurs in Asians. And it's called ossification of the posterior longitudinal ligament, OPLL is what it's called. And the cause is not known, but it can definitely cause cervical myelopathy. It's a big problem. Here's a 45-year-old Asian male presents with trouble mousing and dropping things. Wife says he's a klutz. He's only like an old man. He's only 45. Neurological evaluation finds hyperreflexia in the upper and lower extremities. So when you tap on his biflex reflex, he almost, it's like he almost hits himself in the face because his elbow flex is so hard. He's got a positive Hoffman's. Yeah, got YouTube videos on this stuff. But yeah, so Romberg's test is positive. He doesn't fall down, but he's really wobbly. So you get a CT scan, and there's a mid-sagittal cut. What do you think? Well, posterior longitudinal ligament should be invisible, like it is here. I don't see it here. Right? Invisible. Whoops, that's ligamentum flavum. Invisible, then whoa, there it is, starting to calcify, getting thick, getting crazy thick here, and it's squeezing. That cord should be 10 millimeters, and that thing is squished down to probably about 6. So he's got compression of the spinal cord, which is presenting as myelopathy. Why? Because he's got ossification of the posterior longitudinal ligament. Oh, that's enough. Yeah, that's enough slides for today. So we'll pick up here tomorrow. See you later.